Cystic Fibrosis, Advanced Clinical Summary for Pediatric Specialists. Overview. Cystic fibrosis, CF, is a progressive autosomal recessive disorder prevalent in individuals of Northern European descent, characterized by mutations in the CFTR gene leading to dysfunctional chloride transport. This results in thickened secretions in various organs, most notably the lungs and pancreas, with a significant impact on respiratory and digestive systems. Diagnostic criteria: newborn screening, immunoreactive trypsinogen IRT test followed by genetic testing for CFTR mutations. Sweat chloride test, gold standard with values 60 millimoles per liter indicative of CF. Genetic testing, identification of 2 pathogenic CFTR mutations. CFTR functional tests, nasal potential difference measurements or intestinal current measurements in ambiguous cases. Clinical manifestations: respiratory, progressive lung disease marked by chronic infections, notably with P. aeruginosa and S. aureus, bronchiectasis, and respiratory failure. Gastrointestinal, pancreatic insufficiency leading to malabsorption, steatorrhea, and failure to thrive. Liver disease and distal intestinal obstruction syndrome (DIOS) may also occur. Reproductive, male infertility due to obstructive azoospermia, reduced fertility in females. Treatment approach: 1. Maintenance of lung health, airway clearance techniques, daily regimen to mobilize mucus. Mucolytics, hypertonic saline and Dornus alpha to reduce mucus viscosity. Antibiotics, tailored regimen for chronic colonization and acute exacerbations. Inhaled tobramycin for Pseudomonas colonization. Anti-inflammatory therapy, high-dose ibuprofen in selected cases. 2. Nutritional support, pancreatic enzyme replacement therapy, fat-soluble vitamin supplementation, high-calorie, high-fat diet. 3. Management of complications, CF-related diabetes, CFRD, insulin therapy as needed. Liver disease, ursodeoxycholic acid for cholestasis. 4. CFTR modulators, target specific mutations to improve or restore CFTR function. Examples include ivacaftor for gating mutations, and combination therapies like lumacaftor, ivacaftor for patients with 2 copies of the F508del mutation. Pharmacotherapy, bronchodilators, albuterol as needed. CFTR modulators, based on genetic mutation and patient eligibility. Antibiotics, depends on sputum culture results, include inhaled, oral, and IV formulations. Mucolytics, Dornase alpha and hypertonic saline. Pancreatic enzymes, dosage based on meals and snacks. Insulin, for CFRD management. Monitoring, pulmonary function tests, regular assessment to monitor lung function decline, imaging, chest x-rays or CT scans to evaluate disease progression, nutritional status, regular assessments to adjust dietary and enzyme needs, sputum cultures to guide antibiotic therapy. Prognosis, the median life expectancy has improved significantly, approaching 45 years due to advances in treatment, particularly CFTR modulators. However, the disease remains chronic and progressive, with variability in severity and prognosis among individuals. This summary provides a comprehensive overview of CF management tailored for pediatric specialists, emphasizing the importance of a multidisciplinary approach and personalized treatment strategies based on the latest evidence and guidelines. A 7-year-old boy presents to the pediatric clinic with his parents who report that their son has had a persistent cough for the past 3 weeks. Initially, they thought it was a common cold, but the cough has worsened, becoming more frequent and productive with thick mucus. The boy has also experienced intermittent episodes of shortness of breath, especially after physical activities. His medical history is notable for recurrent sinus infections and a diagnosis of failure to thrive in early childhood. His growth parameters are below the 5th percentile for his age. The parents also mention that he seems to sweat more than his peers, often leading to dehydration and salty skin, which they notice particularly after sports activities. On physical examination, the boy appears underweight for his age. Lung auscultation reveals diffuse wheezes and crackles bilaterally. Digital clubbing is noted in his fingers. His abdomen is distended with visible bowel loops, and a rectal examination reveals the presence of fatty stools. The pediatrician orders a sweat chloride test based on the clinical presentation, which returns with a chloride level of 85 millimoles per liter. Further genetic testing confirms mutations in the CFTR gene consistent with cystic fibrosis, CF. Management Plan 1. Airway clearance. Initiate daily chest physiotherapy to aid in mucus clearance from the airways. 2. Antibiotics. Begin treatment with inhaled tobramycin to address chronic Pseudomonas aeruginosa colonization inferred from the clinical presentation. 3. Mucolytics. Start hypertonic saline nebulization twice daily to enhance mucus clearance and Dornase alpha once daily to decrease mucus viscosity. 4. Pancreatic enzyme replacement therapy, PERT. Prescribe pancreatic enzymes to be taken with all meals and snacks to improve nutrient absorption. 5. Nutritional support. Refer to a dietitian specializing in CF for a high-calorie, high-fat diet plan, along with supplementation of fat-soluble vitamins A, E, K. 6. CFTR modulators. Evaluate eligibility for CFTR modulators based on the specific genetic mutations identified, aiming to improve CFTR protein function. 7. Follow-up. Schedule regular follow-ups for pulmonary function tests, nutritional assessment, and monitoring of treatment efficacy and adherence. Prognosis. With early diagnosis and comprehensive management, individuals with CF can lead longer and improved quality lives. Regular follow-ups and adjustments in the treatment plan are essential to managing exacerbations and monitoring disease progression.